for the population.
Very exciting to see that you will be reaching 5% very soon, and I hope that New Zealand won't be too far behind.
This has been a consumer-initiated and consumer-driven revolution, both in Sweden and in many other countries where harm reduction products have made an impact.
We have succeeded in getting smoking down to 5% level. And you should be proud of that.
Sweden, the land of the lowest smoking rates by far in all of Europe. So low that this year, in 2023, it is set to become, according to official criteria, smoke-free. It's a goal that the EU has asked its member states to achieve by 2040. Most are on track to miss this target, but Sweden will smash it by a staggering 17 years. The country's smoking rate just 15 years ago was more than 150% higher than it is today. The Swedes have shown us the way to be safer and healthier, just like they did when they not only invented the 3-point seatbelt, but donated it to every car manufacturer in the world for free. The seatbelt has saved well over 1 million lives since a Volvo engineer came up with the idea in 1959. Sweden's latest public health miracle could save 3.5 million lives in the next decade if we accept their latest gift to global public health. You see, the Swedes have now effectively wiped out cigarette smoking by developing a specific policy formula that makes alternatives more accessible, more acceptable, and more affordable than cigarettes to consumers. The results speak for themselves. Swedes have long used education, tobacco control measures and snus to keep smoking rates down. But the introduction of modern tobacco-free alternatives, vaping in 2015, and next-generation nicotine pouches, which followed in 2018, turbocharged the smoking decline. In the last decade, smoking rates in Sweden have fallen by an astonishing 55%. The rest of the EU's smoking rates are, on average, 5 times higher than Sweden's, because they have a less supportive policy approach to cigarette alternatives. Compared to the rest of the European Union, Sweden has 44% fewer tobacco-related deaths, a cancer rate that is 41% lower, and 38% fewer deaths attributable to any cancer. If every other country in the EU followed Sweden's example, up to 3.5 million European early deaths would be prevented in just 1 decade. World-renowned public health experts agree.
I think we have the answer already.
Tell the world about the Swedish experience and the mixture of pros and cons that we have had that have been helping people to leave cigarettes and get into something else. It's important for the governments to tell the consumers that if you need your daily nicotine, use this instead of the cigarettes.
And this is Sweden's gift to global public health, and why the message to the world when it comes to smoking is quit like Sweden. Smoke-free Sweden 2023.
Hello everyone. A big welcome to you all, and thank you for joining our event today. So my name is Jessica Perkins, and this is my co-moderator, Dr. Delon Human. We will briefly introduce ourselves and the purpose of today's session, then I will quickly run through the agenda. So just a quick word about refreshments. So there are drinks and some food in the area outside of the room. So for the next 2 hours, if you do get hungry or thirsty, please do help yourself to some refreshments. And then regarding Wi-Fi, if you need to access the internet, the name is Intercontinental, and there's no password. So Dr. Human, would you like to quickly introduce yourself?
It's a great pleasure to have you all here today in Warsaw. Welcome to Smoke-Free Sweden and the launch of the follow-up report. My name's Delon Human. I'm a specialist physician and a very keen follower and supporter of Smoke-Free Sweden. So very pleased to be here today. Thank you for coming.
Thank you. So as I said, I am Jessica, and I'm a scientist, I'm a chemist, and I have worked in the area of tobacco harm reduction science for 11 years, and more recently in advocacy and health communications. Today, we are here for the launch of the Saving Lives Like Sweden report, which is our second report about Sweden this year. Earlier in March, we hosted a launch event of our first report, and you have a copy of it on your chairs, titled The Swedish Experience, a roadmap to a smoke-free society. And this report outlines just how Sweden has reached the historic milestone of becoming the first EU country ever to reduce their smoking prevalence to just 5.6%, whilst the rest of the EU is at a smoking prevalence of 23%. This is thanks to the Swedish way of making alternative smoke-free nicotine products widely accessible, acceptable, and affordable. Our second report, being launched today, Saving Lives Like Sweden, and you also have a copy of that on your seats, is a follow-up report and is a call to the WHO, or the World Health Organization, and global public health to study the harm reduction strategies so successfully employed by Sweden. More importantly, it's a call to develop updated databases of tobacco-related deaths and scientifically sound methods to calculate the size of the prize for public health. This report offers facts, analysis, and calculations of the number of deaths and disability-adjusted life years averted in Sweden and life years saved as a result of the harm reduction strategies adopted by Sweden. However, there are significant limitations to make these calculations, not least because WHO data on tobacco-related deaths is outdated, and several assumptions need to be made to determine a best estimate for key health metrics in Sweden, and then comparisons of Sweden with other countries. Therefore, this report invites critique of methodology and encourages debate and development of more accurate databases and methods. This compelling strategy has the potential to dramatically alter the future for countless smokers, potentially saving millions of lives around the world. Now, to provide some acknowledgements, the authors of the report express their gratitude to the research team and for all the contributors around the world. And production of the report was coordinated by the Smoke-Free Sweden movement. Now I'll just present the agenda quickly for today. So I'll now introduce the speaker biographies. I have some slides. And then I'll hand over to Dilon, who will introduce the report. He has some slides on the report, and we'll go into some of the details. We then have panel session 1, in which each of the speakers will come and join us on the stage. Session in which more general questions will be posed to some of the speakers. We then finish at 7 p.m. and there is a networking session in the area outside of the room where we'll have drinks and canapes, and we encourage you if you would like to stay for that so we can talk to some of you. Now for the speaker biographies. So I'll skip over Dilon. So firstly we have Dr. Anders Milton, who is a Swedish physician, and he is currently a consultant in the healthcare sector, and he has his own company called Milton Consulting, and is also the chair of the Snus Commission. Then we have Dr. Konstantinos Varselinos, who is a Greek cardiologist, and he has been instrumental in developing the evidence base for tobacco harm reduction, not only in Greece, but worldwide as well. And he's actually one of the most cited tobacco harm reduction scientists. He has his own website called ecigaretteresearch.org, where you can find his publications, so I encourage you to have a look at that. We then have Professor Tsar from here in Poland. She is a trained physician, and her specialties are internal diseases and clinical pharmacology. And she's currently head of clinical pharmacology at a leading medical university here in Poland. Then we have Dr. Hossi Letlape, who is a South African physician and ophthalmologist, and he's currently the president of the Africa Medical Association and president of the Association of Medical Councils of Africa. And a large part of Hossi's career was to advocate for HIV patients to be better able to access antiretroviral medication. We then have Professor Mariva Glover, who's come all the way from New Zealand, so a long way to be in Warsaw. And she is an Indigenous behavioural scientist and also the director of the Indigenous Sovereignty Research Centre of Excellence based in Auckland in New Zealand. And she works very, very hard to build Indigenous people's capacity to respond to and reduce the harms caused by tobacco smoking. We then have Federico Fernandez from Argentina, but he lives here in Warsaw, and he's an interesting guy. He's an economist, and he's the leader of an organisation called Somos Innovación, or We Are Innovation. And this organisation is a network of 30 think tanks. And this network finds solutions to problems through innovation. So it's a pleasure to have you all here. And then last but not least, we have Carissa During. So Carissa is from Sweden, and she is studying clinical psychology at Uppsala University, and she is a very keen advocate of using nicotine pouches to move away from smoking. And she's also the director of Considerate Pouches, which is a platform that represents people who use pouches around the world. We then have Professor Mihaela Raescu, who is Professor of Dental Medicine at the University of Bucharest in Romania, and she's an expert on the benefits of tobacco harm reduction regarding oral health. So, over to Dr. Delon Human to introduce the report.
Thank you, Jessica, and again, welcome to all who have joined us here in Warsaw for this exciting new chapter of Smoke-Free Sweden. And I would just like to give you some context on behalf of the 15 co-authors of this publication. Now, not all of us smoke or vape, but all of us were part of the COVID pandemic. And it's worth remembering that during COVID, and specifically during 2021, there were 3.5 million deaths. And may their souls rest in peace. And we were all part of a big family on earth with the COVID pandemic. At the same time, in 2021, there were 8 million people dying of tobacco-related disease. So to bring context to our discussion today, don't forget this. And I would ask you that if you think about smoking, think of somebody close to you in your family, so that you personalize what the potential solutions might be for that person. Now, this is all about Sweden today, so I just wanted to quickly show you what global public health did during COVID. During COVID, and this is not a conference about whether the COVID vaccine was efficacious or not, but this is based on a Lancet article where it showed that with the vaccines in place, we all became amateur epidemiologists and simulation experts in our different countries. And we all knew what the R factor was. And we measured the R factor and even competed between countries of how well a country's system prevented and controlled the COVID infection. And what was measured was firstly the number of deaths, the number of life years saved through that. And you can see that in COVID's case, vaccines did make a difference. And this was evident in this chart, which was published in The Economist. So moving on to the analogy of Sweden and tobacco harm reduction products, let me just refer you to that section in the report where we refer to the number of tobacco harm reduction products, or also known as smoke-free or non-combustible nicotine alternatives, mainly being the nicotine replacement therapies that we know, gums and patches, which very few smokers actually enjoy because they don't feel that they are patients. But then in Sweden in particular, you have the oral nicotine pouches, the oral smokeless tobacco, vaping products and heated tobacco products. And as you can see here, and as explained in the report, it's a continuum of risk with these products. None of them are risk-free, as indeed the COVID vaccine was not risk-free. So just remember the analogy as we continue with this. And then another concept that we wanted to highlight in the report was the so-called disability-adjusted life years. Now, if you can imagine, let's call this guy Eric. If Eric was born and had a healthy life and then started smoking 30 cigarettes a day, and then suddenly at the age of 45, 50, started coughing and started showing, let's say, symptoms of lung cancer. Eric would then be in a situation where his life years would be minimized, or he would be so incapacitated with emphysema or other symptoms that the last years of his life might not be as productive as it could have been. So we call these DALYs, or disability-adjusted life years. This is a big deal because if you can reduce the number of DALYs in any country, you have more productive people, you have less expenses for your healthcare system, and it has to be measured, just as we did with COVID. So in this report, what we've done is we've used the database called the IHME database. It's the Institute for Health Metrics Evaluation at the University of Washington in Seattle, which carries a 20-year database on the global burden of disease. And it's most probably the most representative database on Earth, even surpassing that of the WHO, which is up to about 2004. And what we wanted to see was the difference between Sweden and the EU. And firstly, we know that there are 44% less tobacco-related deaths in Sweden as opposed to the EU. There are 41% lower lung cancer rates and 38% fewer cancer deaths in total. You can see the detail in the report. We've mapped out the EU Eurobarometer data, just so that you can see that there's a clear difference between Sweden and the rest of the EU. That then translates into reduced deaths. So the age standardized mortality in 2020 for all cancers in WHO, you can see Sweden is the clear winner. And if then you go on and you look at the premise for our report, is we then wanted to determine how many deaths would have been averted had the European Union or other countries the same rate of tobacco-attributed deaths and disease as in Sweden for that period between 2000 and 2019. And the overarching figure for that, and please let me just repeat what Jessica said, there are limitations, of course. There are many variables that could not be taken into account for this particular report, and we welcome improved methodologies. But in our calculation that there were at least 2.9 million potential deaths averted if the EU had used the same tobacco attributable policies that Sweden had used. Life years gained about 103 million, and then this famous DALYs, 107 million. We then went further and made sure that if in Poland, for instance, the same rate of tobacco-attributed mortality as Sweden had been employed in the last 20 years up to 2019, the potential deaths averted in Poland would be about 442,000 and 2.9 million deaths averted. On DALYs, you would see that in Poland, in the period of 2000 to 2019, 17 million DALYs would have been averted. So 17 million more life years of productive work, less healthcare cost would have been in place if the Swedish model were followed, and within the whole EU, about 107 million. So as a last connecting of the dots, back to COVID. So if we try and combine and compare COVID with the tobacco epidemic. The menace in terms of COVID was the virus. For tobacco, we know that for every 1 out of 2 cigarette users, they will die a premature death because of tobacco-related disease. So what was done in COVID? Firstly, there was multi-stakeholder engagement. You remember, the private sector, governments, NGOs, they all work together. The question is, has that happened in tobacco control and tobacco harm reduction? Absolutely not. Mostly the industry is cut out, many NGOs is cut out. Secondly, there was a global policy consensus at speed. So in the case of COVID, within 18 months, there was a plan by WHO, agreed to by all the governments, to have vaccine and prevention programs in place. Can we say the same for tobacco control? Absolutely not. In fact, for tobacco control, which is now about 60 years old, why are we still wondering of what the more effective ways of tobacco control could be? Then we had a harm reduction tool. In COVID, it was the vaccine, amongst other tools. In tobacco harm reduction, it's the products that I've mentioned. The oral nicotine pouches, vaping products, heated tobacco, smoke-free, non-combustible alternatives. In COVID, we had multi-sector action. Everybody worked together. The vaccines were produced by the private sector. And in a sense, that's exactly what's happening in tobacco harm reduction. There was measurement, clear measurement, which is not happening in tobacco harm reduction at all. And then clearly there were some deaths averted and some diseases prevented in COVID because of the combined action. And what did it translate into? A win-win-win. A win for the individuals infected with COVID or the individuals who have tobacco-related disease. It's a win for the nation in which they are, and it's a win for global public health. And that really is what the report calls for. It calls for engagement, a global policy consensus at speed with multi-sector action and respect and application of tobacco harm reduction tools. And that's what the report's bottom line is. We need a science-led public health revolution to accelerate the end of smoking by combining the strong principles of combustible tobacco control with a regulatory and fiscal framework that incentivizes smokers to switch to safer nicotine alternatives. The ambition of then becoming a smoke-free nation is entirely achievable, not only in Sweden, but around the world. Thank you very much for this introduction.
Thank you very much, Dilon. So now that brings us nicely to our first panel session. And I'm going to ask each of the speakers to come one by one as I announce your name, please, to the stage. So first of all, Anders, can you go next to Dilon?
I will try.
And then we'll have Konstantinos after Anders. And then Halina after Konstantinos. And then Hossi, please. And then Mariva. And then Federico. And then Carissa. Oh, move over. What a wonderful panel we have. So Anders, would you please give us your remarks of the report for 5 minutes, please?
Thank you very much, and thank you for inviting me to this very important meeting. I think that the Swedish politicians are a bit surprised, to tell you the truth. The fact that we have come so low in smoking rate among men, it's 5.6%. And I think the reason is that, I mean, the Swedish government, different Swedish governments have done about the same things as all governments in the European Union has done, restricting smoking, you know, trying to get people to not smoke at the restaurants, at cafes, etc., neither inside nor outside. The difference is, I think, that we have an alternative. Because people have not stopped using nicotine. It's just that they have switched from smoking to snus. And I think that the important thing with snus is that you can use it when smoking is not allowed. You can use it when as doctors, they do use it when they operate, if they have a short operation, because you can put some pouch and you can use it and still be up and running, as it were. So I think that the question is there an alternative? And we have vaping, we have nicotine pouches, we have snus, we have other things. And heated, not burning tobacco. I think it's very, very important that you have that. Otherwise, I don't think we would have come to as far down as we have. And I think, again, it was a surprise for politicians in Sweden. It was a surprise for most people in Sweden that we really succeeded in that sense of getting people off cigarettes and into something else. As you might have seen with the statistics here, about 23% of the male population in Sweden use nicotine daily. It's just that about 70% use snus and about 5% smoke. And I think in that sense we are about the same percentage-wise part of Swedish men that use nicotine daily as in the rest of Europe. It's just that they don't use it in a way that will kill them. And that, I think, is the great and important difference between Sweden and other countries. Again, the Swedish government should be proud of what we have done. And the Swedish authorities, the health authorities, should be proud of what they have done. We haven't come that far yet. I mean, the government, I think, yes, they are proud. But the health authorities, not so much. They will take some time before they realize what we have achieved, and realize that we have achieved something that no other country in no other part in any part of the world has achieved the same success as we have done. Again, because we have an alternative. And I think the important thing is to find the alternatives that are acceptable to people. And again, tell people the truth. I mean, you can get a long way with the truth. And I think it's important to give people information so that they can choose themselves. Do they want to smoke cigarettes and die? Or do they want to use something else and not die? Well, you have to give them alternatives. And as we've seen in our country, people do like nicotine, but they don't want to die prematurely. They want to see their grandchildren grow. And again, I think it's important that we, from the movement against smoking of cigarettes, that we give them the truth, that we tell them what it's about, and give them an alternative. Then I think they will get it, and they will use the alternatives that there are. Thank you.
So it seems that there is greater transparency between Sweden's public health leaders and the general population, and there's a better understanding of the relative harms of risk between cigarettes and other alternative products. How has this come about in Sweden?
Well, I think that, first of all, snus obviously is something that's been around for probably 200 years. It wasn't made in such a way earlier on, but nowadays it's made in such a way, it's fabricated in such a way that it doesn't cause nitrosamines, which means that snus doesn't cause cancer. It doesn't. And I think that we have been trying to tell the people, again, from the Snus Commission side, we only use public statistics. We don't use any statistics we make up ourselves. We only use statistics from the World Health Organization and from the European Union, and we tell people the way it is. And again, most people do want to use, a number of people want to use nicotine, but they don't want to die. So give them something else. Simple as that.
Okay. And I have a question about the WHO and public health leadership. So the official WHO policy is to encourage their member states and the individual health practitioners to get smokers to quit. And they quit by using either nicotine replacement therapy, or NRT for short, or cognitive behavioural therapy, or their support groups. They're the three main ways. And in many cases, the line is you quit or you die. There's no alternative. What is your opinion of this particular strategy?
Unfortunately, I think that the World Health Organization is way wrong. I mean, they as you know, it's the same with the European Union, by the way. I mean, snus is allowed in Sweden, but it's not allowed in the rest of the European Union. Why? Why is that so? Well, they don't want another way of introducing tobacco. But if it's better. So anyway, I mean, I think it's important that we try to get the World Health Organization and the European Union to say like it is. Tell people the proper phrases, as it were. Give them information. And I think that we should be doing more of that. And I think what you have done, what has been done for this meeting, is very important. The fact that you see that if one were to use snus and smoking like in Sweden, there are a number of people that wouldn't die prematurely. And I think it's important to be repetitive in that sense, because I mean our authorities, health authorities, they will not change overnight. It will take some time before they can change, unfortunately. And I think we have to work hard, and we have to see to it that the information is distributed where it should.
So I have one more question. Just to summarise in your own words, what role should the WHO be playing in helping member states to go smoke-free?
Well, I think that the World Health Organization should say like it is. I mean, obviously, snus, or in our case, in Sweden, or vaping, or heat not burn, whatever, or nicotine pouches, it's a dependency. But is it a dangerous dependency? No, it's not. I mean, you can use nicotine in such a way that gives you a kick. The problem with the means that we have in the healthcare sector is that it doesn't give you the kick. Simple as that. It doesn't help smokers to quit, basically. Snus gives, as we have seen in Sweden, the rate of smoking is going down and the rate of snus use is going up. But, it's simple. I mean, use the statistics and be honest. Tell people the way it is. I think that's a good start for a new day.
Thank you very much, Anders. A round of applause. So, Konstantinos, your remarks, please.
Yes. Well, I think that Sweden is the characteristic example defining the difference between being realistic and living in an idealistic dream. Because being idealistic is just a dream. I'm sure that every government and every citizen would love to have zero crime in all countries, zero car accidents, zero tobacco and nicotine use, but this is just wishful thinking. It's not action, and you can't do anything when you want to just accept only zero crime, zero drug use, zero car accidents. The only way of doing that is to prevent people from driving cars. But the car industry has followed the harm reduction approach, and they gradually developed safety systems, from seatbelts to airbags, stronger cars with protection zones, and that's how society moves forward. What has been happening with tobacco harm reduction, which I must stress affects 1.1 billion people in the world, because despite 60 years of extensive knowledge about the harms of smoking, the first reports showing that smoking causes heart disease, lung disease, and cancer were released in 1960 in the UK and in 1962 in the US. So after more than 60 years of knowledge, we have 1.1 billion smokers globally. You understand what an impact a successful strategy addressing this issue would have in terms of health, life years saved and days saved, as you mentioned, quality of life for all these people, and of course even financial and economic benefits in terms of reducing the use of resources for healthcare for all these people, and the reduced productivity coming from these smoking-related diseases. So, unfortunately, and agreeing fully with what Anders said about the WHO, in this specific aspect, they are following an idealistic approach. You know, we don't want people to use any tobacco product, which in reality, it's not a fight against tobacco. It's a fight against nicotine. They just, you know, invent the term tobacco-free society because, and what they're doing with that is, for example, one of the harm reduction products, which is the electronic cigarette, contains no tobacco at all, but they classify it as a tobacco product. And that's really an invention in order to treat a product which contains no tobacco at all. You know, it doesn't matter that nicotine is coming from tobacco, biodiesel is coming from corn, but we don't call it a grocery product and a vegetable product, and we don't sell biodiesel in grocery stores. You understand that you cannot classify a product based on the source of one of its ingredients. It doesn't make any legal or even no common sense, basically. So this tobacco-free war, which is in reality, as I said, nicotine-free war, fails. And it has been failing for years. Of course, smoking rates have gone down. But 1.1 billion people still smoke in the world. And these people have no idea that there are safer ways of getting nicotine. They have no idea that snus has helped Sweden become smoke-free, They have no idea that it's not about nicotine, it's about smoke and combustion. Most people, and that's very, very unfortunate, even healthcare professionals believe that nicotine is the main culprit for smoking-related disease. And we've seen that in studies that I published with Greek healthcare professionals, and several others have published, even including professionals in Sweden, you know. Even in Sweden, where they're seeing the benefits, there are healthcare professionals who still believe that nicotine is the culprit. Now, that doesn't mean that we are encouraging people to initiate nicotine use in any form. But I think that in public health, we should look at disease and death rather than discuss about moral issues. Because if we start discussing about moral issues, then we need to discuss and address the problem, in quotes, of course, of caffeine use. Because the vast majority of the population on Earth is dependent on caffeine. Why are we not talking about caffeine use? Because it does not cause harm. So let them use caffeine if they want to. Well, it's quite similar, the case of nicotine, but the problem with nicotine was that until very recently, until a few years ago, of course, in Sweden with snus it's 30, 40 years, we had only one main product that delivered nicotine to the consumers, and that was the tobacco cigarette. And now we are seeing the paradox that countries allow legally the sales of the most lethal nicotine-containing product, which is a tobacco cigarette, and they ban the sales of minimal harm products like snus. I suppose you know that in the European Union, snus is banned. Tobacco cigarettes are everywhere, and they are sold legally in all countries in the European Union. But snus, which does not cause cancer, it does not cause cardiovascular disease. There are large studies, not done by the industry, but done by universities. Snus is the product with the strongest epidemiological long-term evidence. And we even have the results on a country level now with the reduced rates of cancer and deaths that Dr. Human mentioned before. So we have a perfect example of a country which has achieved a smoke-free status and already experiences benefits in terms of reduced health risks and reduced rates of disease related to smoking. But it seems that some organizations do not want to learn from this experience. For example, the European Court said that Swedish smoking rates are not low because of snus, but because of paternity leave. It was one of the arguments used by the lawyers. And that's why public health is not about lawyers. Yeah, I'm sure. I mean, it doesn't make any sense.
Don't forget Swedish males' healthy living style.
Yes. Now, if someone can explain me what's the reasoning of allowing, in any country in the world, legally the sales of the most lethal nicotine-containing product and banning the minimally harmful, if harmful in any way, snus, another nicotine product, I mean, we should create an award for someone who will give us a reasonable explanation for that. And that's going to be the end of my comment for now.
Thank you very much, Konstantinos. I have a question regarding the evidence base needed to validate smoke-free Sweden. There seems to be an inadequate database and understanding of what and how smoke-free Sweden came about. How can the patterns of smoking use, consumer behaviour and successful smoking cessation be better recorded and made available for research?
Well, I think that in Sweden, in fact, we have very convincing evidence. Because, as Anders mentioned, it is a product that has been used for years, and they had a lot of time to perform long-term prospective cohort epidemiological studies and examine the effects of snus versus, not versus smoking, but versus not using any nicotine product. So in most of the cohort studies examining the risk of stroke for snus, the risk of myocardial infarction for snus, the risk of oral cancer or lung cancer for snus, they compared snus users with non-smokers, non-users of any other nicotine product. And they found that the risk was similar, irrespective of the duration of snus use, irrespective of the consumption of snus. Even those who were consuming high amounts of snus on a weekly basis did not have any elevated risk. And that's astonishing, to have such a product, which is not, of course, a medical product. It's not a pharmaceutical product. It's a consumer product. An effort to quit smoking, which is self-funded by the smoker, and to ban smokers in Europe from having access to such a product. And you know, these transitions and the health benefits are not going to come in one day or in 1 year. Sweden experienced a switch from smoking to the use of snus since the 80s, for many years. And we know that smoking causes disease for many years. So we need to have this transition for a long time in order to experience epidemiological benefits on a population level. Sweden has succeeded. I wouldn't say because the government, really encouraged people to use snus, but at least they didn't discourage them to the level that they have been discouraged in other European countries of using not only snus but also other products, because we are seeing a fearful attack against all nicotine products, all alternative to smoking nicotine products, with the main argument that they are similar to smoking, you know. Or another quite misleading argument that they may be less harmful, but they are not risk-free. You know, everything we do in our daily lives is associated with some harm. Walking down the street and the pavement to come here and talk is associated with some risk. I'm taking measures to minimize this risk, but the risk is not going to be, never going to be zero. So, by emphasizing the residual risk and the residual harm, which is absolutely minimal for snus, it's proven beyond any doubt, because we have 30, 40 years of evidence. And again, attempt to emphasize the minimal, if any, harm, and not discuss about the tremendous benefit for someone who is smoking and is being encouraged to use an alternative product which is combustion-free, and that's the key message, to have products which do not involve combustion. I find it, as a medical professional and as a public health expert, quite disappointing, to be honest.
Just one very last question for you on flavours, one of your favourite topics. Over the last 2 years, you have published reviews on the use of flavours in smoking cessation. And now, do you think that flavours have played a role in the smoke-free Sweden experience?
Okay, let's understand something. People smoke because they like smoking. And if we want to convince them to use an alternative product, they must like the alternative product. By having a strategy, which I'm seeing in several countries, of making these products, the alternative products, less appealing to the consumer, we are just creating a failure, in the same way that nicotine replacement therapies have been a failure for years. You know, they have the lowest smoking cessation rates, if any, because there are many studies which dispute that there is no benefit in terms of smoking cessation for NRTs, because they're not good enough for a smoker to experience, you know, the positive effect that they experience from smoking. So, if we fail to understand that even adults, even elderly people who smoke, want to have some pleasure from an alternative product, not only in terms of nicotine kick, but also in terms of flavor, taste, you know, throat hit that many smokers want and to experience from smoking. Even the visual effect of seeing something that they exhale. You know, every smoker is different. But if we don't understand that, and we are trying to make horrible alternative products, then, you know, we don't understand, we don't have a basic understanding of the psychology and the effect of smoking dependence. And if we fail to understand that, I don't think that we will succeed in creating more smoke-free countries like Sweden.
Thank you very much, Konstantinos. A round of applause, please. Halina, would you care to give 5 minutes of remarks on the report, please?
Thank you. First of all, I want to thank to be co-author of this report, as well as for invitation for this discussion. In my country, situation is very difficult when we compare to the Sweden. Why is it difficult? Because our governments, our authorities need the analysis, very strong statistic analysis from our population. There is one point what we need to do to be better and wider introduce the alternative product. That is absolutely important. The second point, which is very, maybe much more important than previous, that we need the very detailed described what is the harm reduction. Because, as you mentioned, my previous speaker mentioned that people don't want to hear about it. That only we have cigarettes in the market, and a few, just only a few percent of this market, just these alternatives. So it's difficult because the authorities should know what is the harm reduction, tobacco harm reduction. We try to explain, based on the model in Sweden, that is they're using some alternatives product. And alternatives, the word, just it's not good in Poland because alternative medicine, alternative something else. So we need to just very exactly think what we should give the name for this product to the better understanding for our politician and for our health people responsible for healthcare system. There is a one. The second is the education. When I meet with my colleagues in hospitals, they said, "What are you talking about? Electronic cigarettes and nicotine pouches is the same range of the problem." I said, "No, you should remember that we have differences." So we have like in a primary school, we have a lot of work because we need to explain, first of all, for a physician, for a doctor, generally the doctor, that we have a possibility. There is a first lesson from Sweden. We have a possibility. We should talk to smokers what kind of the choice they have. They should to decide. So we need to very correctly present of these alternatives. What is it? What the percentage is degree of this toxicity comparing to combustible cigarettes? There is absolutely important. We should talking to the doctors, and so education is the very, very important. And when I read this report, analyze this report, I see absolutely a big work in Sweden that takes a lot of, not so much years, but there is a very, very careful was conducted. And what else? Poland is not a country with the low morbidity and mortality of the cancer. We still have a problem with this. And we now know that prevention is the new goal of the future medicine. So the alternatives comparing to the cigarettes gives that possibility. And if we think about this, we should think about from my point of view, a clinical pharmacologist, that we should calculate the cost, direct and indirect cost of this. So not only this very expensive individual target pharmacotherapy, radiotherapy, surgery, etc., and combining of this in many cases, but we should also calculate cost of each person. They probably lost capacity to work, they'll have a problem with the social functionality, etc., etc. The population is quickly going down, so there is also a reason what we should think about this problem. The second is absolutely, in my opinion, very important, that mortality and morbidity due to cancer is a very good suggestion to talking about new alternatives. Why? Because I'm a physician also, so where I give diagnosis the cancer, I must tell the patient, do you have a cancer? There is a very high psychological problem with this patient and surrounding. So there is a completely different when we tell them, do you have a coronary disease? It's not the same. We should calculate this. So we have many lessons to learn from the Swedish, and I hope that in next few years, because I'm not so optimistic in this 2040, and that we are going to slowly but in a progress in this. So we can introduce the alternative in more percentage to the market.
Thank you, Helena. I have a question about the safety of nicotine. So you have more than 160 published articles, and you have played a significant role in pharmacological research. And as a pharmacologist, you are familiar with nicotine replacement therapies, which have been used in the pharma industry for the last 4 decades. Yet there seems to be some concern about the safety of nicotine delivery systems. And in terms of safety, quality and efficacy of smoke-free nicotine models, what principles need to be emphasized to ensure consumer safety?
I think that ensuring for safety consumers should come from the principle of standardization, because we should respect it very strongly, and there is a problem in my country also, probably in many countries. So only certified standardized products should be in the market. Because we, from such quality of the product, we can say it's much safety than other, which is not what is contained. What about the standardization? For me, like a pharmacologist, is the absolutely important few factors. First of all, is the quality of the nicotine, quality of tobacco. If we're talking about nicotine, I think that should be pharmacopoeia purity. It means about 98% purity. If we're talking about tobacco, we need to save this tobacco product without pesticide, insecticide, etc., chemical substances. There is one point, because the quality means what we can observe in biological effect. The second is not dosage, but amount of nicotine in some products. So there is absolutely, we need to know that, for example, in nicotine pouches, the amount of nicotine should be not more than 20 milligrams per unit. Because when the nicotine will be absorbed, they receive the concentration about 16 nanograms per liter. There is quite enough. So if we're talking about this amount, we should know and remember that absorption of nicotine from other products is completely different. So the second is a dosage or usage. So we should very correctly describe how many units per day the consumers can take, and how this influence on the body. Nicotine is an alkaloid, is very, very well recognized from many, many years, from previous century. So we know the activity of nicotine depends on the dose. So low doses is exciting. So we, as all you know, we have a addiction effect. Because from puff, some cigarettes, combustive cigarettes, the nicotine very quickly pass to the blood-brain barrier and receive the brain. 10-20 seconds, it's enough to reinforce your own behavior. So we should compare what's the matter when we use the nicotine in different system. So there is a key information, because the completely different pharmacokinetic of nicotine. There is absolutely important. What else? Not only dosage, not only purity, but also additives. Additives is component in each of products. So they should be orally, for example, in the orally delivered system should meet the criteria for food regulatory. So that is absolutely important. So we have many points which when we can say use this because it's much safer than cigarettes. I'm not talking about the many thousands, more than now about 10,000 substances in the smoke, and more than 70 carcinogens. We know about this. So we're comparing this chemical substances which can induce toxicity. You know, there is no comparison. It's only just 100% and 5% to the other alternatives.
I want to make a comment on what you mentioned, with which I agree fully, but the vast majority of what we mentioned, we already have them. Yeah. In Europe, in 2014, we voted for regulation for electronic cigarettes, which contains everything you mentioned. So, all ingredients should be of pharmaceutical grade quality, including nicotine, but not only nicotine, propylene glycol, glycerol, all the main ingredients. They cannot use any additives which are genotoxic, carcinogenic, or toxic in any form. Mainly they use food-grade ingredients. In reality, no single chemical was invented in order to be used in electronic cigarettes. All the compounds that are used in electronic cigarettes come from the food industry, with the exception, of course, of nicotine, which is coming from basically the pharma industry because it's pharmaceutical grade. I also agree with what you mentioned on the toxicological profile of different products. We already have plenty of data and evidence and published studies examining the toxicological profile between the two products. I mean, I've done studies myself, and it is impressive. Just the smell in the laboratory when you collect an extract of tobacco cigarette smoke, it's impressive to just look at the extract and smell the extract, compared and the contamination of all the materials in the lab when you create a smoking, a tobacco cigarette extract. And you see nothing like that with any of the other products, and I've tested both electronic cigarettes and heated tobacco products. The staff in the lab who for the first time were introduced into such a study were shocked by the results. Even, just simple sensation, just looking at the extract and smelling the lab and seeing how difficult it was to clean all the materials in the lab after collecting the smoking extract. So we do have most of what you mentioned already, not just as an initiative from the companies or from the industry, introduced into European legislation. And it seems that still it's not enough for most governments. And that's really unfortunate.
Can we just, thank you. Thank you very much, Konstantinos, for that. Can we just thank Halina, please, for her valuable insights? So, Hossi, your remarks, please.
I guess my first remarks are, I don't know, it's because of my dark complexion, but the two lights are on me, and I'm blinded. So I don't know if there was a bit of a bias, being the only one with large melanocytes. But having said that, it's very difficult to know where to start. One of the key problems is that when it comes to tobacco, policies are based on fear and what we don't know. And when you come to other things, policies are based on reducing fear and on what we know, and collecting data on what we don't know. Dillon gives an example of the COVID example in terms of vaccines. There's a lot that was unknown. When you emphasized what was not known, you are called vaccine denier. And the WHO went forward on what was known and based the policies and recommendations to government on risk evaluation, risk-benefit analysis. But when it comes to tobacco, it's not based on what we know. What gets emphasized is what we don't know. How it can affect children, how it can attract youth. what's going to happen in 30 years. And you base policy on what you don't know. And that is the basis for banning snooze, was on what if, what we don't know. And I don't know what informed the Swedes to have the exemption, but basically because it was a product that was being used, it was part of their culture. They'd been using oral tobacco for more than 200 years. All that had happened is a scientist in 1967 decided it's unhygienic, put it in a sachet, and the rest is history. It was not done for scientific basis. It was done for hygiene purposes. And it had great benefits. And they proceeded. So I guess what we need to know from the Swedes is what happened there. Because my impression is that there's still public health in Sweden. And it's not like the public health community in Sweden is different from public health elsewhere, that they were all kumbaya about snooze. No, they were not. But for some reason, because it was part of the culture, it was allowed. And we now have 50 years of epidemiological evidence. But the policies were based on, let's make rules on what we know. Let's commission science on what we don't know. Let us not promote fear in society. But when it comes to tobacco regulations, it's the reverse. And it's disappointing when you look at what the WHO has chosen. When I came into the leadership of the Medical Association in South Africa in 2001, we had a government that created a policy of not providing ARVs. We were able to save millions of lives because of the progressive policies of the WHO at the time, where despite the side effects of ARVs, despite the side effects of triple therapy, the risk-benefit analysis was that it was going to save millions of lives. To the extent that the Director General at the time did something unusual, where he initiated a treatment program from the WHO. Normally, they leave those things to the state. But he came up with the 2x5 initiative, antiretrovirals for HIV. And despite the fact that we didn't have 50 years of evidence of ARVs, we based the policies on what we knew, not what we didn't know, and the cost-benefit analysis of what those things would do. And I approached industry to oppose the government's position. And industry was willing to provide the ARVs at affordable prices, and we saved lives. But on this one, the WHO is on the opposite end of what they do. But it's not the first time. They were against needle exchanges at some point in time. So for us, in Africa and in other low middle income countries, the key problem is the WHO. And we've got to stop fiddling while Rome bends and confront the WHO on this aspect. You know, people ask me, why do you think the WHO is like this on this issue? If you look at it, the WHO on the FCTC falls short on 1D, which is about harm reduction, and misrepresents 5.3. And I've come to think about it that they probably, the guilty are afraid because they operate on being influenced by who gives them money. That's why they're strong on 5.3, not talking to the industry, because they don't believe in themselves. They will do what the funder tells them. And you'll see that in terms of tobacco, they are funded by people that have moral positions around tobacco use. And that's why they have the positions that they have. And it's about time they are called out on this issue and that they are confronted. That given the fact that there are alternatives to combustible cigarette, the evidence of Sweden, 5.3 has been misrepresented, but there's actually no place for 5.3 going forward. Any dispensation that comes from the WHO has to involve people who smoke, has to involve NGOs, has to involve the public, and more importantly, the industry should be at the table. On all the other conventions that we're doing, on climate change, the heavy polluters are at the table. And even on this issue, it should be no different. People talk about trust in the industry. I come from a background where I believe in what the Americans put on their currency that say trust in God. The WHO is not God, and I will not trust in them. And the industry has earned its stripes of not being trusted. Trust has got nothing to do with it. Regulations should be based on science, and they should be based on truth.
Thank you, Hossi. I have a quick question for you regarding health professionals. What role can health professionals play in lower middle income countries and beyond to support their patients in smoking cessation? Just in a couple of minutes, please.
I guess I will turn it around. Health professionals have been kept ignorant about nicotine. None of us can recognize the nicotine symbol anywhere. There's no teaching about addictions in medical school. There's no teaching about nicotine. And that's the fundamental problem. You then have the problem where everybody looks up to the WHO, accreditation of medical schools, accreditation of curricula, and the WHO being what we look up to. And most countries, and not only low middle income countries, all countries look up to the WHO as gospel. Otherwise, you wouldn't have the nonsense that's happening in Europe, where snus is still banned, where they are now going to ban nicotine pouches. It's because the problem is with the WHO. And unless we deal with the WHO, you can't deal with education of healthcare professionals, because they are the trusted organization, and they are leading us all to our quick deaths, if you like, nicotine. So the issue is not just about the curriculum. The issue is not about the fact that we are not taught. The issue is about the one who's supposed to save us is the one that is misleading the public about nicotine. That you have the WHO promoting arguments that says electronic cigarettes are more harmful than combustible cigarettes. And you have a minister that bans e-cigarette in India being given a prize by the WHO. I was amazed at hearing in the other session someone wearing a t-shirt that says FCTC, forcing consumers to combustibles. And that basically is what the WHO represents now in terms of the FCTC. It's no longer a framework convention for tobacco control. It was written for combustibles. It is great for combustibles, but it does not apply to non-combustibles.
And let's all thank Hossi for his powerful remarks. So, Mariva, your remarks, please.
Thank you very much for inviting me to be part of this panel and this report and the series of travels to talk about saving lives like Sweden. It's been an absolute pleasure. This is very important, and if I just sort of talk about New Zealand for the moment, I can't remember how many years it has been now that we lobbied for snus to be legalised, for people who smoke in New Zealand to have access to snus. It goes back a long time. I remember working with Murray Logerson 30 years ago in public health, and we talked about snus. The cultural aspect came up. That just works there. It doesn't work anywhere else. It won't translate to other cultures. I believe that was wrong, that decision or that discussion. We didn't even try. But we spent years lobbying for snus, and we could not get the New Zealand government and the public health, the doctors, tobacco control to accept the evidence that has been there for some time that snus saves lives. However, the New Zealand government has regulated vaping, and also the heated tobacco products came in were classified as a tobacco product, and so they're also in New Zealand, but because advertising is banned, nobody knows about them, and they have a higher entry price. So mainly it's vaping. When the vaping regulation was put through, snus oral nicotine pouches nearly got through, and at the last reading in the House of Parliament, they cancelled it. No, they said no. So with vaping, we have had a rapid reduction in smoking prevalence, and New Zealand is close, but no cigar. We are down to 8% on average nationwide smoking prevalence as at the end of 2022. That's not bad. Our smoke-free goal, several years, 10 years maybe, was set. It was set as an aspirational goal, 5% or below by 2025. So we only have 18 months to go to reach that. We might reach that. The people on high income, 60% of the people who smoke, of the population on higher levels of income are already roughly at 5%. The difference with Sweden is that we have, I think, a wider range in terms of inequity in the population. We have 4 main ethnic groups, and there is vast ethnic differences in income level and in privilege and education and in status. In New Zealand, we have a lot of marginalisation. And one of the differences, I mean, you also have Indigenous people, the Sami. And I tried to find statistics on what's the difference between the Sami and non-Sami population in Sweden. One thing you have is somewhere along the line, we're not going to mention ethnicity in public about whether it's crime statistics or even smoking statistics, and that was done to avoid the stigmatisation. In New Zealand, we do mention the prevalence rates by ethnicity. So there's one difference. I hope we will get there, but it will be the people on the higher incomes that get to 5%. As I said, they're already there. People on the lowest incomes, we're looking at 19%. We're looking similar to some of the European Union countries. So we've got some way to go. I just want to really, even if you look at this one page and the number of lives that could have been saved, almost 2.3 million. There's a psychological thing. It's hard for people to get their head around or to imagine 2.3 million lives could have been saved. In my research with people who smoke for many years, I remember in my PhD, and I was interviewing people who smoked in 1998, 1999. And there was one Māori man, and I went to see him out in a rural area. He had 3 children. He wanted to stop smoking because his wife had died from lung cancer at a very young age. He had 3 small young children, and he was afraid that they were going to be left with no parent if he died as well. These lives are real people, and we need to put faces to them. We need to understand that they are mothers, they are fathers, they are grandfathers, they are grandmothers. I dance, and one of the dance teachers I know, her son had a heart attack at 35. We know from Pito's work, people start dying from 35. That's young. Many people live to older age and then die of smoking-related diseases. I mean, if you look at the DALYs, the number of life years lost to disability, it's massive. This is massive. I can't get my head around it. In New Zealand, we only have 5 million people. 4,500 to 5,000 die per year from smoking-related diseases. You know, that's enough. But this, how? How can any health professional, policy analyst, politician, how do they sleep at night when this could be prevented? We've always said for 30 years in tobacco control, smoking is the largest preventable cause of premature death and smoking-related disabilities. We knew it was preventable. And yet, what the interventions, the strategies have been the least effective. The strategies have been the least effective at preventing those disabilities and deaths. Why didn't we choose? Why are we not choosing to reduce these numbers faster? That's what we need to be asking. This is absolutely unethical. It's unethical. And, you know, I guess as an Indigenous person, a little bit, you know, sceptical about governments and what they think about marginalised groups. And, you know, we sometimes think, yeah, they don't want us around. Some of the policies seem to be deliberate. But really, why do they accept this many people dying and developing diseases? It is preventable. Sweden is an example. New Zealand is an example. The UK is an example. We need to be saying why. And this is absolutely unethical and it needs to stop.
Thank you very much, Mariva. I have a quick question for you regarding... I just have one last question for you regarding the whole of society approach to tobacco harm reduction. So, Mariva, you embody team spirit and support for the disenfranchised, the poor, and isolated individuals and these groups so well. And it seems as if in Sweden, there is more respect for all stakeholders and groups. Is this something that we can all learn from and apply elsewhere in the world? Just in a couple of minutes, please.
Yes, I think that, again, going back to that difference, that in Sweden there was a different, more compassionate, and it's not necessarily just tobacco, it's across society. It is not okay to stigmatise groups. It is not okay to demonise them. If you want unity and harmony and going forward together as a society, then, you know, you don't allow that and you take measures to stop it. When you incite hatred towards groups, minority groups, then nobody cares that they're dying. Nobody cares if a policy is going to make their life worse, is going to mean that they can't feed their children, is going to mean that you know, they stay stuck in poverty. Or say you ban something and you impose a fine, and if they can't pay the fine, they could end up in court, and then the fine like triples. And if they don't turn up to court, well, you're going to dock their benefit, their government welfare payment by half. You know, people are being driven out of society to the margins on purpose, and inciting hatred towards marginalised groups is part of getting people to not care that these people are dying. And Sweden has taken measures to, that's not okay, we don't do that. Don't stigmatise. So don't stigmatise and understand why it's happening, and the interracial, interethnic dislike, hatred, it plays into it as well.
We just thank Mariva again, please, for that very powerful speech. So now we have Federico Fernandez, who's going to share some slides with us about the results of a recent study that Somos Innovación conducted in Sweden, because they wanted to understand what's actually happening in Sweden. So over to you, Federico, in just 5 to 10 minutes, please.
Thank you. I'll try to be brief. Thank you very much. As I have some slides. Fantastic. Good, thank you. Thank you. Thank you, Jessica and Dylan, for the invitation, for putting up this event. I'm very happy, and I feel really we are in a celebration here, because we are. And by the way, I mean, I'm not going to be talking about football, unfortunately, but this is a little bit like sports in the sense, you know, there are sometimes records that it seems that are never going to be broken. And then somebody runs, you know, like faster than, and then you see in other parts of the world that the same thing happens, you know. It's like when you break that barrier, it was like a mental barrier almost. And I think Sweden represents that. And I think we are all here gathered together because Sweden is winning. And what I want to talk, and you know, what we want from We Are Innovation, add our 2 cents for the conversation, let's say, is why is Sweden winning? And since I have very little time, let's start with a detour, if you allow me. I'll try to be brief anyway. This gentleman has nothing to do, as far as I know, with Sweden or with, you know, harm reduction whatsoever. This gentleman is Garrett Camp. He was the co-founder of Uber, the ride-sharing company that now does a lot more than that. And what was Garrett's predicament in the early and mid-2000s? He was living in San Francisco. He didn't want to drive, and he wanted to see his girlfriend, by the way, and he was totally dependent on taxis. And taxis were the most unreliable thing ever in San Francisco. So what he ended up doing was calling, Carissa, you had to call taxis, probably you don't know this, but that's how it worked. He called all the companies, and hopefully that somebody will show up. He says he has no proof, but probably he was blacklisted from every taxi company in San Francisco. But at the same time, there was something in his mind from another movie from that time, Casino Royale, the James Bond movie. At one point of the movie, James Bond is looking, I think it's an old Ericsson phone that has a screen, and he sees his car on a map coming to him. And that got into his mind. And in 2008, Apple launches the iPhone. The iPhone had GPS, had maps. And then he said, my vision now can be true. I can call a car with my cell phone, and I can see how it comes to me. And that was the seminal idea of Uber, by the way. That's how Uber became a reality, and in many ways solved public transportation, or many of the problems of public transportation. Why am I telling you all this? Sweden has done a lot and has applied a lot of the recipes that are recommended by the World Health Organization, by the European Union. They have also spent a lot of money trying to educate the population about the hazards of smoking, and that's fine, and that has worked to a certain extent. But what we think is the missing piece that Sweden found in order to defeat smoking is innovation. And it's basically allowing and almost enabling innovative nicotine products to be available for people who want to quit smoking. And that is the secret sauce. And that's why we really think innovation is what is the missing piece, the key ingredient of the Swedish story. In order to find out more about this, as Jessica mentioned, we wanted to know what the people who walked this path thought about this reality, and we commissioned Ipsos to do a poll of ex-smokers who switched to innovative nicotine products. Maybe that's how we should call them, innovative nicotine products, not alternative. And I will share you very briefly some of the results. By the way, you can find the full study on weareinnovation.global. But, well, this is not a surprise, but it's important to mention why people switch to innovative nicotine products: because of health. That's the main reason by far. There are other factors, but health is definitely the most important topic. Another thing that ex-smokers in Sweden highlighted is that it's important that there is a wide variety of products available. Snus is still extremely important in Sweden, but more innovative, more modern alternatives such as vaping and nicotine pouches are growing as well. In the case of women, there are a few things that I want to have. Sorry, I forgot that I have it here. In the case of women, there are a few things I want to highlight specifically. Snus is not the most important product at all. Nicotine pouches is the most important product, and vaping is twice as popular than it is in men. The same with certain key issues that I'm going also to discuss in the general population of the survey. But asked about the being available to get to get the product in the flavor of choice, half of the women said that was very important. They marked the top of the responses they could select. Men only said 37, and in the case, I'm just checking my, I'll try to finish quickly. And men said only 37. In the case of nicotine levels, more than a third said that they were very important, and in the case of men, only a quarter. Very quickly, and Jessica, don't kill me, I'll finish as soon as I can. Going back to the general population, flavors and nicotine levels are very, very important. The same as being able to find the products in a competitive price. These products should be priced competitively, and 61% of the ex-smokers said that finding these products at affordable and cheaper prices than cigarettes, combustion cigarettes, were key in order to facilitate the switch. And another important issue is 54% said it would be very important to find the products in numerous stores, and almost half said that also it's important for them to buy them online. I'll wrap up, just want to highlight two things. Firstly, how we see this and what we learned from what the Swedish ex-smokers taught us. We believe, and Sweden has managed basically this, they have made these products accessible in the sense there are various retail channels in which you can get them. These products are also acceptable for the ex-smokers. That's the person we have in mind, the sense you can more or less get them in the nicotine level if you want and in the flavors you want. And they are also affordable. And Sweden, this was by the way, highlighted by a former Minister of Finance. Sweden taxes snus way less than they tax combustion cigarettes. I think it's quite late, so I can invite you to a glass of wine. Why? Because, and with this I'll finish, Jessica, really this is not a lie. Think of yourself of a good winemaker. And this is how we see Sweden, in the sense there are the most common grapes, the ones that are the backbone of the wine, the base of the wine. And those were the recipes from the World Health Organization. Those were the recipes of the European Union to a certain extent, because Sweden never banned snus. And that's okay. But the most exciting part, the part that made the model and complete this puzzle, is innovation. Those are the unique parts of this blend. And this is how Sweden has achieved to create this magnificent wine that we are celebrating today. Thank you very much.
Thank you very much. Interesting to see that flavours and nicotine levels were the most important factors for enabling the switch from smoking. So thank you for that. Just have a couple of questions for you, Carissa. So I'm going to ask you a question about the consumer voice. So, unfortunately, it is rare for consumers to be given a seat at the policy-making table. Has your group, Considerate Pouches, been adequately consulted by the WHO or governments or key influences in tobacco harm reduction policy?
Yes, and first of all, thank you so much for inviting me. I'm really glad to be here and celebrating the Swedish experience and what Sweden has managed to do. As you say, the interest in general for the consumer voice is not high enough, I'd say. We are, however, talking a lot to members of parliaments locally, member of parliaments, and also on the European level, the members of European Parliament. So there is an interest, but we are still waiting on our invite from the WHO to come and talk to us. I think that if you look at it from a politician's point of view, what is the most important for our politicians, that is their voters. That's where their trust is. And all around the world, there are people starting to consume alternative products to smoking. They can say themselves that this is something that have changed their lives, and it's changed their lives for the better. It has enabled them to make healthier choices for themselves, so that instead of consuming nicotine in a way that will kill them, they can consume it in a way that make it enjoyable and that will not take a toll on their health. So there is an important role to play for consumer and consumer advocacy groups in bringing this into the attention of the policymakers and into the politicians' point of view. Because there's a lot of us, and we can speak for ourselves and say that we've tried this, we've lived this experience, we know what it's like, and you need to listen to us because these are products that are saving our lives. They're saving our lives every day. They've been doing it in Sweden for several years, and they also have the potential of doing that in the rest of the world. So I think raising our voices as consumers is a very important part of making the politicians and policymakers actually listening, making them listen to our experience.
I just have one more question about consumer choice and allowing consumers to make informed choices about what products they feel they need. How can we ensure that adult consumers are given accurate information in the differences in risk between these alternative products so they can make the best choices for them?
Yeah, so first of all, governments all over the world are giving out health information. This is the first place to start. Governments need to provide accurate scientific information that is based in science. That's the first part of it. And once that is done, we also need to make sure that doctors and health practitioners also promote these alternatives to their clients. There's a lot of people that needs help for quitting smoking, and they also need to be informed of what are their alternatives, because if you don't know, you can't make a healthier choice. And as we've seen, there's been a lot of alternative ways of trying to make people stop smoking through therapy, etc., but it only works until a certain point. Some people really want their daily nicotine, and then we need to make sure that they can consume it in a safer way. And the third part of it, I think, is also that it needs to be reflected in the taxation of these products. It's a very indirect way of telling consumers that, okay, the dangerous products, those are the ones that are going to be taxed the most heavily and be more expensive. Because then you can make an easy choice for yourself, both for your health, but also for your wallet, to choose a better alternative, a healthier alternative. And this is also something, as stated, we can see in Sweden. Sweden has implemented these kind of policies, and it sure has helped people transfer from smoking to using safer alternatives.
Thank you very much. Can we please all applaud Carissa for being a strong voice for the consumers? Right, so that ends our panel session 1. I'll now hand over to Dilon for panel session 2.
Thank you for making a marvelous job and introduction to this report, Jessica. And if I may ask Mihaela to join us on the stage, please. Please. Sorry, Mihaela. Mihaela is Professor of Oral Health and Dentistry at the University of Bucharest in Romania, And as you can see, we've heard wise and such good sense from a panel representing so many stakeholders on Earth. Oral health is one of those stakeholders that is probably most underrepresented along with consumers. And I would like to ask Mihaela, what would you say would be the benefits, the oral health benefits for adult smokers who cannot or will not quit, but who then want to switch to lesser harmful nicotine alternatives?
Thank you. Good evening, everyone. Thank you very much for inviting me to this wonderful event. I know that I am the last speaker, so I will not speak too much. And I'm the last one because everybody are afraid to go to the dentist. So if I'm a dentist, I will try to tell you that sometimes if the key word for all the alternatives is innovation, that means the innovation can bring you, let's say, in a very pleasant way to the dentist. Why? Because I did some research about the bacterial plaque, the amount of the bacterial plaque when a smoker, when an adult smoker is switching from normal cigarettes, from traditional cigarettes, to some, let's say, non-combustible products. And I saw that it's quite a big difference between the amount of the bacterial plaque that we can observe in a smoker mouth, in a traditional cigarette smoker's mouth, comparing with somebody who is doing this switch. So less bacterial plaque means less inflammation, less gingival inflammation. That means the bacterial plaque is easier to remove. So it's more pleasant to see the dentist. But leaving this apart, if there is any risk in using snus or some pouches, it is the most manageable risk because we can observe immediately in the oral health, I mean in the mouth, we can immediately observe directly using only clinical examination, and also we have also devices with green light, and we can examine also very quickly if something is happening. So we don't have inhalation, we don't have combustion. So I didn't study the snus or some pouches. I didn't study the effects on oral health, but from a dentist point of view, I think even if it is a risk, small or big, we can easily observe it, and with the preventive oncological exam, which usually is performed by every dentist, we can encourage people to use some alternative. So if you also we can see the difference when we make implant treatment. Let's think about, in every family, each of us, each of you may have may have a problem with the tooth loss, and maybe you will need an implant therapy. Just keep in mind that if you want to make some kind of treatment, you have to stop smoking. So what can you tell to your patient, relative, friend? How can you have a successful treatment if you don't stop smoking? So don't say, please don't smoke, because the patient will go outside and after the treatment will grab a cigarette very quickly. So please give them some alternatives. And it was right, my co-presenter were very right about the information. It's a very good thing to be informed. You have to give to the patient a very well-informed advice, because usually they keep in their mind the advice coming from a doctor. And if the doctors are not informed, how can they explain to their patient that they have an alternative or not? So thank you.
Thank you, Mihaela. A warm round of applause for Mihaela. So we're approaching the runway. We're in the last 15 minutes of our session. It's about this report. And nobody could have said it better than Mariva, who looked at the statistics and asked the question, why? Why are policymakers not paying attention to the miracle, the public health revolution that's taken place in Sweden? Why? And isn't it high time that all stakeholders should engage on this, measure, and make sure that the lessons learned in Sweden and elsewhere, New Zealand, Japan, United Kingdom, why aren't these lessons learned, analyzed, and then applied elsewhere to save lives? So, Mariva, thank you for that clarion call. And then to Halina. Halina, thank you also for asking the question, how much? And as a pharmacologist, I think that she made a very valid point. When you do pharmacological innovation, you always bring into it the budget and what sort of costs, what the risks are, what the benefits are, how many dollars can be saved by this innovation. Halina, perhaps from your perspective, if you were the coordinator of a massive, innovative nicotine project worldwide, what sort of costs would you look at? What needs to be studied to make the argument for tobacco harm reduction?
There is a very difficult question because we must think, first of all, about what kind of the studies we need to show. If we need I think just only about the clinical studies, so the cost will be more high than in the previous year. So I don't know exactly. We must calculate. But this calculation is nothing to the lost the life.
Thank you. Well, in the report, you'll find that one study that was referenced is by Daruti et al. And Daruti calculated the average cost for every disability-adjusted life year. So in future, this has to be part of the debate. How many deaths could have been averted? How many life years could have been saved? How many disability-adjusted life years could have been averted? And how much cost could have been saved? It makes obvious sense. So thank you for making that point. And then, José, with the lights all on you, you've been a tireless advocate to help improve access. You've often spoken about tobacco harm reduction as a human right. And in fact, when in South Africa, when the antiretroviral therapy for HIV/AIDS was still at that stage not accepted and in a sense de facto banned, Nelson Mandela called José to come and educate him on HIV and antiretroviral therapy. And long story short, it ended with access to ARVs. We commend you for that, but we're in the same position in tobacco control. How are we going to improve and secure access for adult smokers who want to switch to a less harmful nicotine alternative?
I think the problem, at least in the South African context, you had to speak the language that our politicians would understand. And unfortunately, they speak a different language. Civility doesn't work with them. So some of us had to expose ourselves by accusing the head of state of promoting genocide against the people. Then suddenly you get attention. And I think the issues that Marewa raises about the numbers is going to be important. So that you highlight the fact that there's 8 million people that die every year. We're all frantic about 3 million deaths that came from COVID. Less than 8 in 3 years from COVID. Does it mean people who smoke are lesser human beings? So that aspect of humanizing people who smoke is important. Because in the HIV debate, the people were dehumanized. It was a question of, this is men who have sex with men. This is a white man's disease. This is for homosexuals. So once it began to affect heterosexuals, once you began to have mother-to-child transmission, it had a human face. So part of the issue is putting a human face upon people who smoke, so that they are no longer sinners. It's no longer a sin tax. That there's no harm in enjoying nicotine, but there's a responsibility in ensuring that it is delivered to people in a safe form. So that we simplify issues, that the problem is about combusting tobacco. Let's move to non-combustibles, but highlight the fact that smokers are human too. And the other key issue is to ensure that things are regulated, not banned. You can only provide public safety through regulation. You don't provide it through banning stuff, because then people can't research it. People can't access it safely. You can't come up with product standards. And then you are basically putting it into the dark, and you are endangering society when you ban things and you don't regulate them. And there's this moralistic thing about making sure that, you know, we don't enjoy ourselves. He's talking about no to this, no to this. If governments had it, there'd be no to sex. But I guess they understand that their populations would disappear if it was no to sex. So there's this issue about Calvinism around issues, about deciding for humanity, not giving people information so that they can make an informed choice. And I guess maybe part of the Swedish culture is to accept that people have agency. People can make their own decisions. All you need to do is to provide them with credible information so that they can make informed choices. And that's probably where we need to go to. But we need to stand up to a WHO that is misguided when it comes to tobacco, because everybody looks up to them for proper information. They've saved us on HIV, but they are killing 8 million people. So lastly, misinformation is the biggest killer today. And in tobacco harm reduction, the lead misinformer is the WHO.
On that point, though, WHO plays an extremely important role as the world's premier technical agency in public health. And rightfully, when you ask Director General of the WHO what is the single most important factor in tobacco control and, in a sense, also against tobacco harm reduction, they would say is the prevention of youth initiation and the prevention of youth use. I'm going to ask for a cheeky intervention here, and I'm going to ask Chase Wallace to come to the stage. Chase is a medical student from the Emory University in the US. Chase, you form part of the cohort of the 18 to 35-year-olds. You're much closer to the 18-year-olds. But I'd like to ask you, where is the difference in the consumption of information? You know, Josi spoke about misinformation. So do young people consume their information in the same places and channels as older people? And if so, how can we prevent youth initiation and youth use of nicotine products by using communication in the right way? Can you tell us?
Absolutely. Thank you for having me. The most important thing in this issue, especially when dealing with youth usage of vapes and nicotine products, is to tell youth the truth. And this has been extremely clear with an American venture. I'm from America, I've seen it firsthand, where an organization sponsored by the government called The Real Cost has been pushing to me, to a lot of people of my generation, and the millennial generation above me, a lot of anti-vaping rhetoric. And one look at their website shows that they give a list of what are different types of tobacco products. And they have a little click-through page, and one of the things is vapes. So they group it in automatically with tobacco products, whereas it's supposed to be, as we've seen here with all of these wonderful panelists, showing us scientific evidence as to why that is not the case. They should not be put on the same level, because nicotine in and of itself does not cause the damage that tobacco does in combustible cigarettes. But the main point of this is to say that the real cost, this organization pushes these messages to my generation. They specifically focus in their advertising on pushing it on Instagram and Snapchat and YouTube, which are the programs that among the circles of people I know are the most widely used from my generation. And they're very obviously the content material is based towards younger people. So one could postulate when you ask how there can be a dissuasion from having children or younger people be introduced into vaping, and a persuasion for older generations who already smoke and need that quitting tool. The key is advertising on the internet through the right channels to the right people. So the key is making sure to focus on the harm, the potential risks, whatever they may be, for vaping and nicotine products for children, pushing that along Snapchat and Instagram and YouTube, and making sure that that is differentiated from wider tobacco products. But only limiting that to the younger people, and then taking a separate advertising campaign with older people, older generations, current smokers who are already tobacco smokers, and through that emphasizing the benefits of smoking cessation through these products. And I would suggest something like Facebook for that, because Facebook is more typically used by older generations. So the main point of all that is to say, use social media to promote the risks of vaping to youngsters so that they don't get started in it in the first place, and for older generations, promote the benefits of these nicotine products for smoking cessation. It's very important.
Thank you very much, Chase. Warm round of applause to him. Well done. We're in the last 3 minutes of our session, and I'd like to perhaps just quote one of the probably most effective Director Generals that the World Health Organization has ever had, which was Gro Harlem Brundtland from Norway. And she always, her mantra was, when any complex public health problem had to be solved, it was always 3 words, which was evidence, evidence, evidence. I'd like to ask Konstantinos. Konstantinos, do we have enough evidence? Or shall we look for more evidence to make the case for tobacco harm reduction as a necessary life-saving strategy in contribution and complementing tobacco control?
Well, it depends on how anyone defines the burden of proof. Unfortunately, in the political stage, particularly in Europe, but not only in Europe, we have the precautionary principle, which has been largely abused. It is a very flexible principle, as you know. You can be as precautious you want, or less precautious if you want to be, depending on the subject. They have set the burden of precaution so high that after 12, 13 years of, a lot of evidence now concerning products like electronic cigarettes, and 40 years of evidence on snus, even evidence on a country level, they still apply the precautionary principle, because for snus we may have something different after 50 years. With electronic cigarettes we may have something different after 20 years. And I remember since I started doing research in this matter in 2011, that in the first 2 or 3 years they said what's going to happen in 5 or 10 years. Now it's more than 10 years, they're talking about the next 20 years. I'm sure that in 20 years they're going to discuss about 30 years. And that's always, expanding the use of the precautionary principle by flexing it so much that it becomes, just a non-justifiable argument simply to apply restrictions and bans. So I think we do have a lot of evidence to clearly state that, based on current knowledge, there is no doubt that many products are available in the field of tobacco harm reduction which are by far less harmful than smoking. Of course, there are also differences between these products, and we even have enough evidence to classify these products, the harm reduction products, and identify the differences by themselves. Of course, we are not at the stage, with the exception of snus, we're not at the stage that we can accurately quantify the level of risk difference in terms of developing disease, because this is a clinical endpoint that needs 40 years of evidence. But using the argument that we don't know what's going to happen in 40 years is basically a ticket for never learning what's going to happen, because unless you have these products available and used by the consumers, we will never be able to gather evidence on long-term use and effects. So using the argument of the lack of long-term evidence to ban a product means at the same time that they don't want to ever have long-term evidence. And that creates another paradox, similar to the paradox that tobacco cigarettes, the most lethal product, is available legally everywhere, and minimal risk products are banned.
Konstantinos, thank you. And as a last word, I think it's only fair that we ask Anders. Many people arrived after you spoke, and I would like to dedicate this Saving Lives Like Sweden to tireless advocates like Anders, like Carl Fagerström, and all the Swedes in the audience, and all the Swedes out there who have shown the way to the rest of the world. I invite you again to look at the report. I invite you especially to look at the calculations of how many lives could have been saved, how many deaths avoided. Remember this disability-adjusted life years. This is a topic that has not been given the emphasis that it deserves. And like Alina pointed out, the cost involved in those DALIs is just as important. We never talk about that, and we should be talking about that. So please use the report to go to your policymakers in your various countries and make sure that they answer the question that Mariva posed. Why are you letting people die needlessly? And I applaud you for that. Thank you. Anders' mantra for this is, tell the people the...
Yeah, I mean, be honest. You know, tell the people the truth. It's an uphill battle, because it will take some time to get the activists on the other side to understand the difference between smoking and not smoking. But I think we cannot give up, and we should be very long-term, long-term in our approach. Thank you.
Thank you, Anders. On that note, a big thank you to Jessica, my co-moderator.
Yes, I wanted to say a huge thank you to all of our world-class speakers, and also a huge thank you for all of you for coming and giving up 2 hours of your time to listen to our wonderful speakers and to learn about Sweden. And there is a website called smokefreesweden.org where you can access some really valuable information about the Swedish case study. There are fact sheets in multiple languages, and you can download the 2 reports electronically from there as well. And there's relevant information on thr.net too. So happy reading. Thank you for coming. There's a networking session and drinks and canapes outside, so you're welcome to stay till 8 o'clock. So thank you very much. Anything else from you? No. Thank you.